your hospital and that kind of thing? Yeah, just what I say. Kind of. All right, okay, great, thanks. Hi, everybody. We're here at the 2022 meeting of the American Academy of Pediatric Ophthalmology and Strabismus here in Scottsdale, Arizona. I have the pleasure of speaking with Dr. Scott Atkinson today. Thank you very much for joining us, Dr. Atkinson. Can you tell us a little bit about your practice?
Yeah, I'm a pediatric ophthalmologist at Children's Mercy in Kansas City, and I'm a regular old pediatric ophthalmologist. I am no electrophysiology genius, but a few years ago, our practice needed somebody to work with electrophysiology and ERGs, and I said, well, I don't know anything about ERGs, but okay. So the first few we did were under general anesthesia with the larger traditional machines with all the wires, and the results we were getting were hard for me to read. I thought they were kind of cryptic. So our chairman said, well, how about this new device? This is back in 2016. It's handheld, and you can use stickers on the eyelids, and you don't have to put the kids under anesthesia. And I said, where do I sign up for that? Not knowing, what a great display and set of results you get from the device. So it's all been a good ride. It's been a good journey in my electrophysiology life.
Excellent, excellent. So what type of patients do you see in your practice?
I see, my practice is everybody, but the ones we do that are specifically related to electrophysiology, I see a lot of nystagmus patients, a lot of unworked up nystagmus. It's been labeled as congenital nystagmus, and we feel like we need to go further these days and try to delve more into those. And we see some patients that are on high-risk medications such as vigabatrin, and those are most of the ones we see are the ones with suspected inherited retinal disease and the pharmacologic side effects.
Oh, okay, thank you. You're presenting a poster this year at the meeting on where RETeval was used in inherited retinal disease. Can you tell us a little bit about your poster and your study?
Yeah, so we one of the things we feel like we have to do with this is to validate it, right? I mean, it's a non-traditional ERG, although it meets standard, it meets ISCEV standard, it's non-traditional. So we thought, well, I wanted to sit down and say, hey, we have a group of patients that we've been doing ERGs on, and the same patients then go on to get genetic testing for inherited retinal disease, and can we find that our results agreed with what we found on genetic testing? So we thought the results looked pretty good, and that's what we put them together for a poster.
Excellent, excellent. When you use the RETeval, where do you fit that in your patient workflow?
Well, for us, it's really easy. I've taught 4 techs how to use the device, and so the patients just come in as part of my regular patient days, and we don't have special ERG days or anything like that. And we have a couple of our rooms set up so that we can really get block all of the light that goes in, and they're regular old exam rooms too. So there's not even a special room for it. They double as ERG rooms, when we need to.
Excellent, that's great. And how do you kind of talked about this a little bit before, how do you compare using a RETeval versus kind of one of those more traditional ERG type devices?
Well, I mean, I think I know where you're going. The ease of use of the RETeval is significant versus anything else out there. And, it doesn't require a genius, which I'm certainly not. And it's a little bit idiot-proof.
That's great. And do you have any, having used the RETeval for a number of years, do you have any recommendations, any tips or tricks that you would say, to your colleagues using the RETeval that you find helpful using this in pediatric patients?
Thanks. Yeah, I think the thing that I've noticed that we really needed to work on was the placement of the electrode. It needs to be very precise, even though it seems like you just slap it on the eyelid. You actually need to have the electrode line up exactly as it shows you on the diagram, and not too far from the eyelid margin, or you won't get the voltages that you want to read when you do this. And as far as doing little kids, I mean, I've learned a lot of verses to wheels on the bus. If we have a difficult kid, I'll go in there and we got a little tambourine, stuff like that. But it's very comfortable for the kids. So if you can just distract them from the thing that's coming toward them at their face, that they're little kids, that usually, almost always, we can get through it.
That's great. That's great. Well, thank you very much, Dr. Atkinson, for joining us today. I really appreciate it. Thank you all for joining us live here in Scottsdale. And just once again, thank you very much.
You bet.
Thank you, everybody. Take care.